represent the many individuals and organisations who have dignified people-to-people links between Scotland and Malawi. And the SNP is especially keen to hear from and be led by Malawians and members of the diaspora, and therefore be responsive to the priorities of our members. That's why we exist. We are funded, both of us, but independent from the Scottish Government. And may I take this opportunity to register our thanks to the Scottish Government for funding both organisations. So just as a start in relation to what this meeting is about, the National Public Health Emergency in relation to cholera was announced in December 2022. And as of the 12th of February, that's just 3 days ago, it's been recognised as the major and indeed the worst cholera outbreak in 2 decades, with over
Oh, God, it's not mute.
by Vibrio cholerae, if we say it, pronounce it properly. And there is an urgency in the treatment of people who are infected to maximise the chance of recovery. So, as of the 13th of February, the President launched a national End Cholera campaign. And with the support, considerable support from the World Health Organization, they hope that the campaign will focus on 3 broad activities: increasing access to appropriate cholera prevention and treatment, increasing access to safe water, sanitation and improved food hygiene, and strengthening the risk communication and community involvement in cholera prevention and treatment. All of these things are desperately important and urgent. In leading up to this situation, there have been 2 oral cholera vaccination campaigns, last year from May to June, and then again from November until January of this year. These have allowed the administration of 5 million doses in 21 districts across Malawi. That's really all that I want to say as an introduction to the topic that forms the starting point of our meeting this morning. But I'm keen now to pass over to my co-chair, Dr. Anne Poya, if she is online in Lilongwe. Anne, are you there?
Good afternoon, Prof. I am here.
Oh, wonderful. How nice to hear you, Anne. I don't know if you heard the introduction about the cholera position.
Yes, I heard what you were saying, just that our network is a little bit a challenge as of now.
Can I hand over to you, perhaps, to introduce our main speaker for today?
Yes, please, I will do that. Are we ready to do that now?
Yes, please. Thank you very much.
Okay, let me know if I am audible enough.
It's
Otherwise, good afternoon, everybody. This is Anne Poya, the chair for the Malawi Scotland Partnership. This afternoon, I have the pleasure to introduce to you Dr. Wilfred Nkoma, who is our current chair for the Presidential Task Force on COVID and Cholera. Dr. Nkoma is an experienced epidemiologist who has worked in Malawi for a long time, but more specifically, he has worked with WHO at the regional office, looking at issues of TB and other infections. So he comes to the Presidential Task Force with a lot of experience, and we are all looking forward to his guidance as we address the issues of cholera and other infections. So without taking a lot of time, Dr. Nkoma, you are on the floor. Welcome to the discussion.
you, Dr. Hoyer. Thank you, Chair of the Scotland-Malawi Partnership. It's an honor. I hope you can hear me well. I hope I'm audible. I can see some nodding.
Yes, we can hear you. Thank you.
Thank you. Am I able to share my screen? It's supposed to be done. Getting stuck in sharing my screen.
I believe you need to ask up above to share screen.
And where is that button where I subscribe my request, please? Someone?
At the bottom on Zoom.
Yeah, sorry, on the bottom center, the green should share screen in the center.
Yeah. A pity. The screen, try now. I hope it will work. Are you able to see my screen?
Yes, yeah.
Thank you. So I was saying that it's an honor for me to have been asked to participate in this meeting and specifically to make or to share really the situation of the cholera outbreak. I'm excited on two fronts that it's something that I'm following up, so I think I'll be able to speak from personal experience in the country. But the other one is that every time I hear about Scotland, I'm reminded that I spent 2 years at the University of Glasgow in 1988-89, so it just kind of takes me home. The cholera epidemic, like the chairperson of the Scotland-Malawi partnership started to share with us, has been going on now almost 1 year now, literally, because the first cases were reported at the end of February, beginning of March. And I don't think I need to repeat what cholera is about, but it's caused by a bacteria. The transmission is an issue of water and sanitation because it's passed from person to person through ingestion of contaminated either water or food, or indeed contact items or utensils that have been contaminated by the same. And despite what government and partners are already doing, the activity has now affected all 28 administrative districts of the country. And we have had a significant acceleration of the cases since December of last year, 2022. And that is because that's our rainy season. This is when we normally expect that communicable diseases that are transmitted through water and food, they tend to appear and increase. But in this case, as I mentioned, we had some cases occurring in a lot of districts, even during the dry season. It's a bit strange. And we think that there must be underlying causes for that. There are some known possible reasons. Two of them are that we did have cyclones in the country, two of them, one after another, on some parts of the country, which eventually destroyed a lot of the water and sanitation structures. And that was compounded by the presence of poor water coverage, poor safe water coverage, and poor sanitation coverage in the country. Anyway, as of today, not of today, but actually yesterday, we have had 43,434 cases. 43,400. This is the worst cholera outbreak Malawi has had to deal with so far, and it is not yet over. Out of these, 1,400 passed away. And we are continuing to have a case fatality rate above 3%, most of the time 3.2%. But while it has affected the entire country, we have five districts in the country where most of the cases are being reported from. Literally 60% and 63% of the cases and deaths. I've listed in this table what was actually the case yesterday when 475 new cases were reported. And this is typical of what we have been seeing in the past few weeks. And out of those, 13 people died. And I've listed at the bottom of the table, on the left bottom of the table, the number of countries, about 10 of them that are contributing the most. And they include, sadly, what we call the cities in Malawi, Lilongwe and Lanta. But notably, even like it was at the beginning, the districts along the lake shore. Malawi is blessed with a beautiful freshwater lake. And this is where most of the cases initially started. And to date, those that are in red are the ones that have reported either more than 1,000 or at least beyond 3,000. The trajectory at the moment is showing that we are doubling the numbers, at least since December. We are doubling the number of cases in every 32 days. 32, 33. It used to be 52. Now, if we keep that rate, multiplication of cases, then by the end of next month, of March, we could easily be talking of 2,000. And if we take the 3.3 case fatality rate, we could be talking of 2,300. This is comparing to what we saw in 34 months for coronavirus. We had 88,000 cases and 2,686 deaths. But this cholera epidemic has only gone on now, 13 months. So clearly, if we are going to go at this rate, we could be heading for higher figures than what we saw in the coronavirus. This graph on your right shows that while in some cases it looked like it was beginning to drop, but it keeps going up again every time. So yes, it looks like the increases are beginning to slow down, but it's still an upward trajectory. The 5 districts that I talked about, you can see this graph. The one on your left, just pay attention to the blue bars. The one on the left is Lilongwe, which is the capital city of Malawi, and that's the one where we don't seem to be making enough progress at the moment because the increases continue upwards earnest. Yes, we're seeing some decline in the Mangochi, Blantyre, and Salima, equally in Balaka and Machinga. But Lilongwe, Machinga, Balaka seem to have the same picture, the numbers. Most of these cases have occurred in younger age groups, mostly 2029, 10 to 19 as well. I think this is associated to practice of what these people do for a living, but it has been mostly men. We are not so sure why, but again, we think that the exposure risks are higher for the men because of what it is they are participating in for a living. Deaths too have tended to be mostly men, but this time slightly older men than those that are getting affected for the first time. We have identified, and this has been the case for many years. The last cholera outbreak in Malawi, actually, the bigger one was way in the beginning of 2000, or 2002, 2003. And these factors have operated even at that time. First and foremost, it's unsafe water sources. The coverage of safe water in the country is estimated at around 63%, which means that the rest have to do with water that is not considered safe for consumption. Equally, sanitation coverage is low, estimated at about 43%, which means that a lot of more than 50% of the population does not have access to adequate sanitation, including food hygiene for that matter. And the last one we have discovered, even as we are trying to combat it now, is that the community, the civil society, the public, the masses, do not seem to have adequate information, and they don't seem to adequately mobilize, participate at their level. And so these put together are obviously the four factors that our responses have tried to address. And in terms of addressing, there are four areas where I think I should talk about. First is the governance issue. And the chair of the Scotland-Malawi partnership did mention about the latest development in the country, which is that last Monday, on the 13th of February, the head of state has launched what we have dubbed the NTB, sorry. Dr. Poya did tell you I was working on TB for some time. End cholera in Malawi campaign. We intend for this to be a push on all the four fronts that I talked about, but to go on in every district, led by the district governance team, at least at the minimum, up to the end of March. And these are supposed to enhance the coordination and collaboration at that level, supervise what's happening, resource mobilize, train the health workers as well as other extension workers, particularly those working in water, but also mobilize supplies and distribute the same. Now, as it turns out, we have also heard that Zambia next door and Mozambique next door have also been affected. So they too are going through quite a lot. Therefore, cross-border collaboration has also been identified as an area. Critical is obviously the issue of case management, prevention, treatment, and care. While this is the most visible most of the time, we know that when people come to the hospital with cholera, the hospital system dealing with failures in the water and sanitation arena. And therefore, yes, because of the overwhelming of numbers, there has had to be infrastructure development as well as recruitment of additional human resources, and those continue to be needed. because the same healthcare workers that are initially have been deployed to treatment centers, treatment units, are the same ones that are supposed to be managing the primary sector. And this raises a lot of problems. One addition there was the administration of oral cholera vaccine. It was initially targeted at the 8 districts reported the first cases, but eventually when the outbreak has spread to all the districts, the little that was available was spread out so that all others might also benefit. And not surprising, we ran out after we had used about 5 million doses. A placement has been made with the World Health Organization for more doses than even the 5 million that we got. But we are as yet to receive that, and we don't know how soon that is going to come, because we do understand that there are about 33 countries in the world dealing with cholera at the moment, that the manufacturers may only, like they did last time, manufacture not much more than 35 million doses. So there will have to be a fair share of what little vaccine is available. But we did do. Water and sanitation at the moment is our focus, I think, because we need to improve access to safe water by making functional some old but now dysfunctional water sources, by treating water when it has been brought from wherever it is brought, particularly those that are not piped water sources. There's a lot of chlorination going on. There's a lot of provision of free, safe water by the country water boards. We have 5 water boards, and they are working with the Ministry of Water and Sanitation to make water available, safe water available, either through trucks or opening up pipes in the areas where the people are, particularly in the urban areas. And then the issue of sanitation, obviously, has to take precedence as well, including food, especially in our schools. We don't want a situation where there will be an outbreak. As I mentioned at the beginning, there's a big gap in the community's understanding of this outbreak and what they themselves can do, helping to curb this situation. So we are working on the area of enhancing risk communication, as well as awareness. And so just to show the coverages, oral cholera vaccine at the beginning, when the 8 districts were identified. Then this one shows the second round, which was, I think, better done, because at that time there were a lot of deaths. People were now afraid and wanted the dose for themselves and their families. So not surprisingly, it came close to 97% of the doses that were available at that time. We still have gaps, like I mentioned at the beginning, in the area of case management and prevention. I think I should mention 2 specific things, 3 actually. The first is the facilities infrastructure for caring for the cases. The teaching, cholera control, that you should not move the cases far from where they occurred. That means you must set up treatment units. We didn't have enough, and so an area of need. There is, as I mentioned earlier, also a need to increase the number of healthcare workers that are available to provide these services. Not surprisingly, we also need a lot of supplies caring for patients. The second area is WASH. Like I mentioned, the coverage with safe water is around 63%, and sanitation and latrines is around 33%. And the availability of chlorine, which can be used to make the water safer, the areas where safe water is not available. It's not easily available, or it's not available in numbers. And then, of course, there have been issues regarding people not being very open to some cultural practices. For example, when a death occurs, they call it a camp, the communities sometimes like to follow their usual traditions, rights of the dead person. But this has not always been the medical practice that has been promoted, because the corpses do operate as flyers of infection because of the processes that go around preparing them for burial. Then, of course, there is communication area. We do need a lot of awareness creation, need a lot of. Then, of course, we have surveillance that allows us to keep these cases source as quickly as possible, then have the capacity to diagnose.
Professor, how are you?
And now let me finish by what are we talking about in terms of what are we talking about in terms of what does it cost to do this? We have a national response plan, which is estimated to cost at $56 million for all the clusters that we have identified: health, education, and sanitation, community, as I said, and then public communication. Pretty much we have a gap for those other interventions of about 26 million United States dollars. And for the wash, we have done better, because I think we were able to mobilize adequate resources more than what they are missing. So they are missing around $8.7 million. But the total budget is roughly $56 million. That should take us up to the end of December, including the activities we'd like to implement. Okay, we have a number of partners, and we are grateful. Actually, I don't know how I could have forgotten that we did get something from the government of Scotland through UNICEF for this same activity. But these are some of our key partners, some donors, local NGOs, international NGOs. As I mentioned just now, the government of Scotland has made available £107,000, which was paid through UNICEF, helping, like everybody else, to procure activities that are needed. But recently, together with WHO, they have also put an additional 800 healthcare workers, which will be able to relieve standard primary care workers. I think I would like to stop here and entertain clarifications and questions. I thank you for your attention. I submit.
Thank you, Dr. Nkoma, for your presentation. Participants, Dr. Nkoma has given us opportunity to ask him questions. I have seen also some questions on the chat. I'm not sure if Dr. Nkoma, you can go to the chat and see the questions that are there and start responding to those. In the meantime, those of us that have questions, let us show by raise of hands. Thank you.
Why don't I start with the questions that are in the chat?
Yes, please. Let's do that.
I see the ones from Vij Pi, based in the Longway. Is there any data on safe drinking water and safe sanitation? Yes, as I mentioned, on average, 63% of the Malawi population has access to safe water, and 43% has access to sanitation facilities that are considered adequate. The long-term strategies obviously is to improve those. As I mentioned, what happens in the health sector after this are really failures of the water and sanitation. So covering the country much more will probably be able to prevent future outbreaks of this nature. Correlation between wash facilities and nutrition and poverty. The areas that are most hit, particularly the peri-urban areas, tend to be the areas where socioeconomic status is low. And they also tend to be the ones where the water and sanitation covering, safe water and sanitation is also very low. Not surprisingly, because of the low socioeconomic status, nutritional issues and poverty are obviously rampant in these areas as well. But we should not, I think, infer that cholera is causing those problems, or that these particular problems are the only things that are happening in the area where these shortcomings are What measures have you put in place for prediction of hot sites and use the data to prevent? Do you think there is resistance to antibiotics? There is a surveillance system in the country for communicable diseases for many years, not just cholera. And these operate at every district. They are known as integrated disease surveillance system. That is the one that is being used to manage the data, collect the data, and treat it. And in terms of resistance to antibiotics, the identification of the antibiotic of the bacteria has been done, and initial susceptibility testing for the drugs that are available has been done. And the teaching for cholera control, by the way, is that as soon as you find the first few cases have been confirmed, laboratory confirmed, you usually then connect the others epidemiologically and link them to treatment as long as they satisfy diagnosis consistent with those whose cases have been confirmed. There is now a process going on to do gene sequencing of some of these bacteria to make sure that we are not harboring, for example, and probably unknowingly multiplying bacteria that are resistant to the antibiotic that we are using. But at the moment, management, I think, has suffered from what we think is a quality issue because of the availability of adequate workers, also the availability of supplies in some of these places. There is another question here. What measures have we put in place for people with disabilities? People with disabilities are being treated just like everybody else. Like I mentioned, these are areas quite often where people may not have the necessary resources, both for water and sanitation, but they have not necessarily targeted any people with disabilities. We do have groups here that we consider as people with disabilities, including the socioeconomically disadvantaged ones, including those living with albinism, including those that are physically disabled. And all these, in the case of Malawi, are also eligible for care for free at the point of delivery. Yes, because of that, I think sometimes it is not possible to consider everyone, particularly those that have difficulty hearing and seeing. I think we have had that gap identified even in times of COVID. What we'll have to do is to develop materials that are going to be able to address some of these. Outbreak is typically considering that it started prior to the rainy season. We know why this was the case. I did mention that we had 2 cyclones at the beginning. And the cases that came first occurred in those areas. And so the infrastructure for water and for sanitation had been broken completely. It's still the case now, unfortunately. We are in the rainy season. Some of those same areas are still not repaired, damage that had happened. The vaccine obviously did seem to help. At the moment, while we are seeing this increase overall, we have a number of districts, particularly in the northern region of the country, where we are seeing fewer cases. Indeed, maybe in the last week, most of these have been reported 0 cases, but there are only about 8, 9 districts that are doing this. Yes, the others are also reporting lower numbers, but it looks like those that did better in the vaccination are also doing better. Particularly East. I think these are the questions I see from the chat, and I will move for others.
Okay, thank you, Dr. Nkoma. I don't know whether there's anyone of us who has more questions other than the ones that have already been responded to.
Yes, please. I think there are 1 or 2 here in the room. And I wonder if I can ask, well, first of all, to thank Dr. Nkoma for a really impressive description and detail of what is happening. So perhaps my question coming from Scotland, where we're lucky enough not to have cholera outbreaks, is a little naive, but it links to the question from Dr. Shawa about the timing and demographics. When I was in Malawi in September, there were some cases in the north, and it gives the impression almost as if the epidemic is moving south. Is that simply a factor of high population density and inadequate vaccine coverage? Because your vaccine coverage in the north looks at well over 90%. And associated with that, do you think that this particular epidemic will almost burn itself out by the end of the rainy season, or are there other things that need to be considered for the end of March and beyond, which is when you think the current campaign might end? Thank you.
We take more if there are any.
Yes, if we can take two more questions for Dr. Nkoma to conclude, as I see that we are not doing well in terms of time.
There's another question here from Patrick Carrigan.
Yeah, hi, Doctor. My question is that they found the highest mortality rates are in male, and yet men in Malawi are not around water. It's women that manage water. So has any research been done to find out what's their lifestyle and how come it's the highest population of fatality through cholera is men?
Dr. Nkoma, you can go ahead and respond to those 2 questions.
Can I ask that the second question be repeated, please? I was not quite clear.
Okay, so in Malawi, we have discovered that the highest mortality rate is in men in cholera, but it's the women who collect the water, wash the kids, bath the kids, manage the water, and yet it's men that's the highest mortality rate. Is there anything, do we have any evidence why this is?
It's clear now. May I proceed?
Yes,
Yes.
please go ahead.
The incidence of the cases has shown to be higher in men. And it is our belief that it is the engagement that many have, particularly in the economic front, which is exposing them to situations that are rife with unsafe water and unsafe sanitation. I think sanitation here is obviously the greatest enemy. We are contaminating the water and food with fecal matter. And those that are men in our society, particularly those along the lakeshore, they tend to have no source for adequate sanitation. Those districts that are along the lakeshore, the men are the fisher people. They are the ones that are doing most of the manual work around there, and they help themselves in the water. And when they also want to have a bath or want to have a drink or want to cook food for themselves, they are also drawing water from there. And quite often, they are not in a situation where they can do anything to make that water safer. So they are in contact with that contaminated water most of the time. They are using that contaminated water most of the time, compared to the women who will go to some specified places. And quite often, they may actually be able to boil that water, put chlorine in it. The men are unlikely to be coming home even to drink water that has been chlorinated. When it comes to, is this going to burn out itself? But by the way, let me just indicate that the northern region districts seem to be doing better in terms of having the cases going down now. But they were also among those that were reporting more cases at the beginning. And that was 3 or 4 districts from the north, which are all along the shore. What has happened there, I think, is an act that we must try to replicate elsewhere, which is they are able, I think, using the traditional leadership, which is more solid, to manage the people and allow them to take the messages home. Coverage with vaccines obviously did help. Most of the districts in the north, when they were given the vaccine, the coverage was very good. And we hope that now that they have established the system, particularly in terms of behavior, water and sanitation behavior, bowed by the strength of their traditional system of chiefs and so on, they seem to be obeying this better than the other regions. In terms of religion as well, in the north, you have fewer people that have problems with the burying of bodies on the same day without having to interfere with the body after the healthcare workers have worked. But there are districts, particularly those that are associated with the Muslim religion, who would like to be allowed to treat their bodies the way they would normally want to treat them without breaking their religious beliefs. But we've been just having a lot of discussions, and indeed at this launch on Monday by the president, there were representatives of the leaderships of those religious groupings, and we believe that this is help. The burnout after rainy season, knowing what we have seen since February last year, we would all want to think and hope that there will be a decrease in numbers because the rainy season is going to disappear. But as there might be still a bit of risk factors lacking in the background, which have given us the outbreak since February last year, even during the dry season. I think we need to continue to work on the water and coverage, be able to control it for a long time. I submit.
Thank you, Dr. Nkoma. I think we have gotten the questions from the floor. And at this juncture, I would probably propose that we end here on this discussion. And if we still have some more questions, please send the questions to Dr. Nkoma, either directly to him, or you can send them through the Malawi Scotland Partnership or the Scotland Malawi Partnership. We will make sure that Dr. Nkoma responds to our questions and any other strategic issues that you want to learn as to what Malawi is doing and how you can participate. So, Prof, I don't know whether you want to say something to Dr. Nkoma before we release him.
Yes, well, again, to say a very big thank you, and perhaps I could get everyone to clap visually, if you're We really
I'm humbled. Thank you.
Well, we really appreciate the time you have given us, and it gives us all a lot of food for thought and how best how we can help you and the teams in Malawi. Thank you. But it is right that I think that we move on. Dr. Poya, are you happy for me to take over, or would you like to introduce the Malscott team? I think you know them almost as well as I do.
No, Prof, probably I can only introduce part of the team, but you know your team better. So probably why don't I give you the chance to introduce your team on this subject and favorite subject of yours.
Okay, thank you. Well, many of you know that my favorite subject is the prevention of cervical cancer, not just in Malawi, but originally in Scotland. And I'm very delighted to be able to pass over to the lead of the current Malscott project, Dr. Christine Campbell, and in Malawi, there's Beatrice Kubota, who is our national coordinator and based in Coma Hospital. So Christine and Beatrice, over to you.
Thank you so much. It's a pleasure to be presenting today at the SMP meeting. I have got slides to share, and I think I'll just have to ask colleagues here to take them up, please. My colleague Beatrice is on the line, so that's wonderful too. For those who don't know me, I'm Christine Campbell. I'm a health services researcher at the University of Edinburgh, and my own work in Scotland is also around cervical cancer prevention, as well as other cancers, so very much primary care and cancer. But it's a real pleasure to present with Beatrice an update on the project that's been ongoing now for the last 4.5 years, around moving towards sustainability, really trying to take forward cervical cancer screening delivery in Malawi. Next slide, please. Many of you will know that Malawi has the highest global cervical cancer mortality and the second highest global incidence. And that is very sadly driven by HIV incidence, but also the lack of, until very recently, vaccination and also effective cervical screening. I'll just wait till that's done. Thank you. So the next slide, and part of the reason for that is the dual burden of HIV and cervical cancer. We know that women living with HIV have got a higher prevalence of the persistent HPV, human papillomavirus infection. That's Heather's areas of expertise. And that causes the infection to progress more frequently and more frequently to pre-cancer and cancer in the presence of HIV. And these women are also at a much higher risk of invasive cervical cancer. The most recent Malawi demographic and health survey showed that HIV prevalence in women aged 15 to 49 years is 17%. Malawi has been doing a huge amount of work and has made good progress in reducing that prevalence in recent years, but it's still high. And so that makes the need for cervical cancer screening all the more important. Next slide, please.
So said and done.
Thank you. The World Health Organization, WHO, has a global strategy that it introduced actually during the year of COVID itself to eliminate cervical cancer globally by 2030. What a great ambition. It is ambitious, but at least it's really putting cervical cancer on the map. It's called the 90-17-90 strategy, 90% HPV vaccination coverage in all countries by age 15, 70% screening coverage using a high-performance test, and 90% access to treatment for cervical precancer and cancer, and critically also including access to palliative care. And achieving these targets would go a long way to reducing cases and deaths globally in the next couple of decades. Next slide, please. The Malawi Ministry of Health has been very active in this arena. There's National Cervical Cancer Control Strategy from now 2016 to 2020, which really emphasised the importance of the country and the health service really addressing the burden of cervical cancer. There was a national cancer control strategic plan that really covered all cancers, recognising there's also other cancers that are important in the country. And then the most recent National Cervical Cancer Strategic Plan was released last year. And that's a really high quality, in-depth direction and recommendations for practical implementation, evidence-based interventions. And I'm pleased that some of the work we've been involved in has helped inform that, as well as the work of our partners. Next slide, please. So MALSCOT, cervical screening in cancer screening and mentoring, and it builds on a previous project that was funded by the Scottish Government from 2013 to 2016 that Heather was the lead on. And that provided same day, it showed that the utility and the value of providing same day screen and treat for cervical screening, visual inspection for acetic acid, thermal ablation for immediate treatment, and ensuring robust follow-up pathways, because we know it's not ethical to screen if you can't then follow through for the treatment. And it did include a component examining the use of HPV testing. This project was based at Nkoma Hospital and its health centres. Next slide, please. So MALSCOT is the project that's ongoing, funded again by Scottish Government, International Development Fund, and we're just coming towards the end of the main funding programme. And what that did was to roll out of that effective hub and spokes model to 6 additional hospitals and 34 health centres across Malawi, shown in the map here. And it had very much a focus on rural health centres. There are other partners working in cervical screening in Malawi, doing excellent work, often combined with HIV, but they have tended to focus on the larger cities. And so there was a gap that, in discussion with Ministry of Health colleagues as we were planning this project, really highlighted the need for rural areas. So we work closely with the Ministry of Health, Reproductive Health Directorate, and we've got an academic collaboration with colleagues in Blantyre. Next slide, please. We've all been there, don't we? And at this point, I'm handing over to Beatrice, who's the national coordinator in Malawi. So if you would go to the next slide for Beatrice, and Beatrice, please.
Thank you so much, Christine, for the introduction of MALSCOT project. So I think I'll take you through how far we have gone with the project since we started in 2018. So as Christine has said, that we focus much in rural health centers. And also, before we start with the rural health centers, our aim was to strengthening the hubs who will be overseeing these health centers as we roll out into these health centers in the rural. So the time we are starting, we aim to reach out to 33 health centers, but now we have 34. And before we start with everything, we had to do facility assessment. That is after approval by the Minister of Health under Reproductive Directorate. So after facility assessment, and we have seen that there is a great need to introduce cervical cancer screening in those facilities, we had to do community sensitization with the local leaders as well as the health center staff. Health center staff, we target them as we know that they are our mouthpiece, as they are, most of them, they are coming from within the community. So this was really something which we focus much in order for us to achieve what we wanted to do in order to more women to access screening. So after that, also we are refurbishing the rooms which were identified within the facility. And also let me tell you that all these health centers, we are using the existing staff of structures within the facility. That means the project depends on the existing structures. So we have to identify the room. Once the room identified, we equip and make sure that it is well equipped with standard instruments for screening. And after that, once we start screening, the project made sure that all the consumables are available for the screening to be done without any problem and with the standards. Next slide, please. So far, in all those facilities where we are working, in 34 health centers plus 7 hubs, we have managed to screen 81,077 first attendees. These are the women who have never been screened before. And this achievement is by December 2022, which is against our project target of screening 64,000 women. So I think this has been done because of the groundwork which has been always being done before we start screening. And out of this, all women with the screening who have been screened with a positive cervical precancer lesion have been treated with thermoabrasion. Either majority of them treated on the same day, or after a short postponement of treatment because of other underlying cause. And those who were suspicious for having cervical cancer already, biopsies were taken and sent to 2 of the pathology lab in Malawi. And after their results are out, they are being referred for further management. And I can also say that within the past 9 months, that is from April to December, around 932 women, that is standing 3.9%, have been referred for further or advanced treatment or consultation into other gynecological conditions. So some of the women which we are able to see in these clinics, they have other gynec conditions which they were not aware or they were not sure what is happening to them. So the program helped them also to access those advanced treatment. Next slide. So the project also, the other arm which was focusing is capacity building. The project has managed to train 102 additional providers within those sites. This is against the project goal of training 80 of them. Maybe you can ask why have we gone more than that? I think the other challenge which we have been facing, knowing that most of these facilities are government, also others are CHAM, the staff deployment, and even other providers after being trained, they have gone to further their studies. So we have to replace so that we make sure that screening continues. And also within the hubs or the hub, we managed to train the 23 mentors. These mentors, their aim is to help these new trained providers so that they are equipped with enough knowledge and skills so that when they have gone to their specific sites, they are able to provide quality and standard screening services to those women. So we have those 23 mentors across all the hubs. And apart from that, to make sure that the provider, they have enough knowledge, we do conduct regional quarterly meetings within the region in South and Central and Northern region. Apart from that, we use also to have Zoom meeting, especially during COVID-19. You know that it was difficult for people to convene at one place. So we make sure that we continue having the CPD meeting, and we used to have the Zoom meeting. And in year 5, in year 5 of the project, we had a chance also to have a face-to-face CPD meeting with the 2 Scottish clinicians who visited Malawi in September. So it was an advantage to the provider in order to have other external people to increase knowledge on how we can conduct this screening. And also to add on that, after seeing how these providers were performing, and after also working together with the ministry, 116 providers were satisfied by Ministry of Health, knowing that they have done a lot and also they were qualified so that the ministry can rely on them, that they have these cervical cancer providers who can provide care to our women. Next slide. So The time we started the project, we had no mentoring toolkit. So the project, another arm which was focusing in order to have mentorship within the cervical cancer program. So Mascot project has managed to develop a mentoring toolkit, which is in use in all Mascot sites and is being used as a basis of national mentoring toolkit. The time we started Malawi as a program for cervical cancer screening, we had no mentorship toolkit. So the project managed to develop one and share with the ministry, and the ministry from that managed also to produce now a national mentoring toolkit, which is in use across Malawi. And within the mentorship toolkit, we have also included the issue of COVID-19 as a protection, so that when we are doing when the providers are providing services, they are able to continue protecting themselves as well as the clients. Next slide. And apart from providing cervical cancer screening to our women, the additional support which Mascot project has given is one of the hub, which is Tegelani. The time we started screening, they had problems with their water. As you know, that screening or health services, we cannot do without water in our daily services. So the problem was that at Tegelani, their pump was vandalized. It was stolen by people around or some which they cannot identify. So after consulting the Scottish government, they were able to spare some funds in order to restore the water pump, which currently the water now is running. The same at Tegeran, that is in Cholo district, one of the health centers also where we extended the service there, they had a similar situation. At that is in Gombe Health Center. Their pump was intact, but the electrical cable which helped to pump the water up into the tank was also vandalized. So after still going back to Scottish government, they were able also to spare some funds, and we managed to restore the cable. And also at this site, they have enough water. And to make sure that the cable is intact, maybe what happened should not repeat, the tunnel was filled with quarry and cement so that it is well secured. Next slide. So what I want to share is during now COVID-19, you know, it affected most of the issues and even health services across, and the cervical cancer screening was not spared, that it was affected in one way or the other. But fortunately in Malawi, cervical cancer screening was not suspended. We continue providing the services. And during that time, the project managed to provide PPEs to all their providers, which was also helping even more to those facilities in provision of PPEs. At the same time, because of the COVID-19, we intensify outreach clinic in order to reach out to more women, because most of the women were afraid to come to facility for screening, but they were eager to be screened. So the project managed to go out for screening. As well as during the same COVID-19, after identifying that most of the facility had issues or shortage of oxygen cylinders and the concentrators, also Scottish government spared some funds and the supply with some oxygen cylinder to these hubs within the project site. Next slide, and over to you, Christine.
Thank you. And I've just got a few slides to finish up. I wanted to highlight the Mascot safeguarding policy, where we worked very hard with in-country organisations and with Ministry of Health, with CHAM and other NGOs to develop what we hope are clearly owned in-country safeguarding policies. I don't have time to go into it in detail, but the emphasis is on privacy, confidentiality, behaviour protocols, and protection of vulnerable groups. Next slide, please. And we've developed safeguarding materials, policy, brief summary for all providers, reporting forms, and infographics in local languages. Next slide, please. And we're working with the Safe Motherhood Committee of the Reproductive Health Directorate to get endorsement and hopefully national adoption with other partners to ensure that all cervical screening sites across Malawi are safe for clients, but also for providers. Next slide, please. Malscott also has had a very strong emphasis on initiatives to reach vulnerable women in the last couple of years, and that includes those with both physical and mental disabilities, commercial sex workers, and women with albinism. These are groups that are often very excluded from all sorts of access to healthcare. And over 1,600 women have been screened, and as you can see there, positive lesions, suspect cancers, other gynae conditions have been picked up. So we've been very happy to work with local organisations and advocacy groups to really emphasise that everyone is welcome to screening and is relevant to everyone. Next slide, please. So despite the challenges of COVID-19, we're really pleased and proud of the team in Malawi for the resilience, the recovery and the local ownership that's been very evident. We're working with our academic colleagues to analyse data and to carry out surveys across the country, planning a national symposium, if all is well, later this year to bring together the different partners working in cervical screening with the Ministry of Health. And we're continuing to engage with district health offices to plan for sustainable delivery, recognising the many constraints that are in place. And my last slide. And that's really just thanks to the funder, to Beatrice and her colleagues with who deliver on the ground this work, and my Scottish colleagues, obviously, the Ministry of Health Reproductive Directorate. And I'd really like to mention both Fanny Kachali and Twambaliri Piri, who are both retiring soon and have been true supporters over the last few years. And finally, SMP and MASP. Thanks so much for your attention.
Thank you very much, Christine and Beatrice, for a very detailed and clear explanation. And yes, I have been associated with the project too. It's been both humbling, but also an amazing project to have been associated with. We are running a little bit behind, so there's time for perhaps one, maybe two quick questions before we move on, either from the floor here or from our colleagues online.
It was a question
Patrick.
for Beatrice.
Question for Beatrice, right, Patrick?
Once someone gets diagnosed in Malawi, how do they pay for their care? Is it free, or do they have to pay for the treatment?
Beatrice, did you pick that up?
Yes, I did. If it is the pre-cancer region for cervical, we treat it for free in all the sites. But when it is now, we have taken biopsy and referred for palliative care or for chemotherapy, it's also free because most of those are government facilities, unless if the person sought to go for these other private, but actually for the project and all our sites is for free.
Okay.
Any other quick questions?
There's a question here, Katrina, happy to come back to you. Staff receive their salary while attending a training. They're released from their health centres to attend it because we don't employ anyone in this project. So we do provide some support for the health centre there for release. We pay the mentors from the grant. The mentoring programme is supported through the grant and for their visits. And it's the Malawi government going to take ownership. Beatrice in particular, but also ourselves, have been working closely with the district health offices over the last few years to think about how we can integrate the service. We recognise we are providing funding for the service, but ultimately ownership is in the country. And because of the Malawi government's priority and recognition of the need for cervical cancer, we do hope that basic supplies will be in place. But Malscott's been privileged to be able to provide infrastructure, training and equipment. And so we hope that the basic consumables will be able to be taken up by the DHOs. But that's, as you can imagine, an ongoing discussion. Thank you.
Thank you. I think we'll need to leave the other questions to be answered offline. But thank you again to Beatrice and Christine for that very fulsome presentation. Thank you.
Yes, Prof, I just wanted to say something. This is
Yes,
Anne. I just
yes.
wanted to, in terms of the government taking over the program, I just wanted to add that cervical cancer is one of the priority programs for the ministry, and it is included in the reproductive health strategic plan, including the new health sector strategic plan that has just been launched. So this will continue, and probably the best we can do is just to continue reminding the district health management teams for the supplies and probably repair of equipment, but it is in the current program of work for the country. Thank you.
Thank you. That is a helpful addition and will obviously contribute towards the sustainability of what we all hope eventually will become a national programme, as we're fortunate enough to have here. So if we move on the agenda, this is an opportunity for members to update us on some other activities. And we've got one specific request from Carol McGregor to tell us a little bit about what Sight Savers International have been doing in Malawi. And Carol, I know you're online, so would you like to give your presentation about what you've been doing? Thank you.
No. Carol, you're muted.
Can you hear me okay?
Yeah.
You can hear me?
Yes.
I've got all this thing. Anyway, it's very kind of you to have me here talking about Sight Savers International. I have, in fact, been in Malawi with Sight Savers, and I have, and all the things you're talking about, I mean, I have seen water problems and all that, but Sight Savers do an amazing job as far as giving people back their sight. However, I've written down a bit here. I'll just read to you what I think is important at the moment. The Sight Savers International programme has still been running during this time of the cholera outbreak. The issue for them has been attention and resources are diverted to cholera response and away from other issues, including obviously eye health. Another problem has been lack of foreign currency and its knock-on effects. For example, fuel has been in short supply and impacted on their work, moving supplies from Blantyre to southern Malawi for the construction, for example, of a new clinic. They cannot move cataract surgeons from one hospital to another because of the lack of fuel and or patients from their homes to surgeries. However, there's a very positive and high point for 2022. The Sight Savers International, which came from Malawi as the first country in Africa to eliminate trachoma. Funding came from the Queen Elizabeth Diamond Jubilee Trust for the majority of trachoma work in Malawi. The figure was that 9.5 million people were at risk of going blind. There was a massive push to treat people with antibiotics, eye surgery for advanced trachoma, again, water and sanitation interventions. This was also helped by a highly motivated Ministry of Health and government support. Caroline, the British High Commissioner, the Minister for Health and the President hosted the Countess of Wessex in Malawi on World Sight Day on the 13th of October 2022, which was the point at which the trachoma celebrations were held. The high point of the year was this fantastic news from Malawi. Sightsavers has a number of supporters in Scotland who are very interested in Malawi. And an event is planned later this year, but it will have its focus on Malawi. I hope that's been some kind of a positive thing about Sightsavers, who also do things. I have been in other countries with them, but we're talking about Malawi, and the things they do is quite amazing. And obviously, once we get through all the cholera problems and things, they will get back into what they have been doing with great success. Thank you. I hope that's been of some interest.
Thank you very much, Carol, for giving us that overview of Sightsavers' work. Clearly, restoring sight to people has such an impact, not just for them as individuals, but for their families and their communities and the economic future. So thank you for that. Are there any immediate questions for Carol? Again, perhaps time for one. Well, and a wider question, are there any of our other members who would like to just very briefly say something about the work that they've been doing in relation to health in Malawi? Patrick, okay, very briefly.
Actually, I'm just back from Malawi. I spent the last 2 months there over Christmas and New Year. I was part of the epidemic, the cholera. We had to close our nursery, our daycare centre. We were affected by it. We are still closed due to the high risk and the local people being affected. One thing that, if it wasn't for the clinic workers who walked from village to village, even my staff there, they wouldn't have got the vaccine. They walked in the villages and went to get people who couldn't leave the villages. So it's massive, and it's still impacting people in the villages. So right now, until we are 100% safe, for the protection of the children and the families and the community, we have to stay closed in the meantime. So we're being seriously affected. And that's the sad part of Colin in these days. It's really sad, but that's the work we do. You know?
Really important, and I guess it comes back to the lack of availability of the oral cholera vaccine, which would enable you to at least follow up and give more protection to those locally. Thank you, Patrick. We've also got one online, Tracy, Dr. Tracy Morse. Tracy, over to you.
It's just a really quick one, Heather, just to highlight, I guess, to members that we have a new programme that started on adolescent health and wellbeing that's funded through NIHR Global Health Research Groups. And it's more of a call out to say, you know, we're going to be working across areas of WASH with our social care, social policy colleagues at Strathclyde, and also with Centre for Reproductive Health at CUHES. And we're always excited to bring in as many stakeholders that are working with adolescents, especially young adolescents from across Malawi and Scotland as well. So please get in touch with me if you've got an interest in knowing what we're doing, or an interest to engage or share what you're doing as well, so we can learn from you. That was all.
Thank you, Tracy. Your new research grant is really important and significant both for Scotland and Malawi. So I do encourage members who could link to get in touch as Tracy is asking. So that's particularly operating in the south, isn't it?
Sorry, Heather, I should have said that. Yeah, Blantyre and Mchinji, actually, so central and south.
Thank you. Anyone else?
Just from myself.
Yes,
so
thank you. Jonathan.
I'm new to this group, so I represent Think Malawi. I'm a trustee for Think Malawi. Think Malawi is basically a charity based in originally based in the south of England, now national, and we basically support and fundraise grassroots projects aimed at the education and health sector in Malawi. We've currently got 4 projects that we are funding. We've got a really interesting one in the north, in Mazuzu, which is a prison school. So we're working with the women there on some mental health and also some education issues within the prison itself. We also have 2 primary schools that we're working with. One, that we're building, last year we built the toilet block. This year we're putting the toilets into the toilet block. And we've also got a internet and digital facilities school project that we're working on as well. And finally, again, in the north of the country, we're working with a primary school to provide them with desks and furniture, because one of the challenges that they have in a lot of the primary schools is they're sitting on the floor, and it's generally very unsanitary conditions they're in. Just a quick call out. We're basically, this is our biggest year to date so far in terms of the fundraising, and we're organising a charity bike ride from London to Glasgow. So we're going to have about 30 cyclists basically cycling from London to Glasgow to coincide with the start of the World Cycle Championships, which are happening in Glasgow. I will forward the information to yourselves if you could pass it around. And again, anyone that's interested in either taking part or promoting the work that we're doing would be fantastic and well received.
Thank you, Jonathan, and welcome to this your first meeting. Let's hope you become an active member of Scotland Malawi Partnership and find partners and members in Scotland who can link with you and your teams in Malawi. Thank you. Okay, I think that we're really coming towards the end of our meeting, and there will be a poll appearing on your screens which have 2 questions on them. I presume it's the same 2 questions as those around the table have for their feedback form. We always end our meetings by asking for your comments to see what we could do better in the next time, but also to see what you have learned and whether you can find new partners and new associations as a consequence of attending this meeting. So is that going to just go up on the screen now?
It's on already.
It's on your screen. Thank you. Just take a minute to fill that in. And just before you go, I would like to thank very much indeed Dr. Nkoma, who's already had to leave us, but he gave such an interesting update on cholera. Thank you too to Christine and Beatrice for talking about the Malscott project in detail as it comes to the end of this phase. But thank you also to our members who've been willing to share about their own projects, and perhaps you'll be asked to give more detail at another health forum instead of just bringing us quickly up to date. And most of all, thank you to everyone who has attended, and to my co-chair, Dr. Anne Hoya in the Longway. It's good of you to give your time. I hope you all feel that you have benefited from that time. Thank you and goodbye.
Thank you, Stuart. Thank you, Prof. It was a good meeting. Thank you.
It was indeed. Thank you too.